My name is Mel and I'm the Metastatic Breast Care Nurse here at Breast Cancer Care WA, and it's my pleasure to welcome you here today for our webinar on a user's guide to metastatic breast cancer, which will be presented by Associate Professor Andy Redfern. Before I introduce the webinar, I would just like to formally acknowledge the traditional custodians of this land that we are on today. We at Breast Cancer Care are streaming from Wujak Noongar Boodja, and I would like to pay my respects to elders past, present and emerging. Before we get onto this webinar, just some housekeeping. You will see that your cameras and your microphones have been disabled, and that's just because we will be recording this webinar today, and it will then be posted on our website within a few weeks of the presentation today. Equally, you will receive the recording of the registration of the webinar sent to your email address. So if you are having any technical issues today that we can't resolve, please don't panic, because you will receive the recording once it is done. We welcome and encourage questions throughout this webinar. So you will see on your screen, depending on how it looks for you, that there is a Q&A box either at the top or the bottom of the screen. So feel free to tap on that and type in your questions as we go. Andy is doing his webinar in sections, so he said he will address some of those questions as we go along, and we will do our very best to get to as many as we can. The reason we are holding this webinar today is to honour Metastatic Breast Cancer Awareness Day, which fell on October the 13th. This day came about to really shine a light on the unique challenges that people face with this disease. These challenges are ongoing and ever-changing and are often invisible to those around them. So it's really important that we highlight these challenges so that people can get the right supports in place that they need. Metastatic breast cancer for a very long time has not always received the attention and the focus that it's deserved. But thankfully, over recent times, and perhaps due to some of you that are watching this webinar today, things are starting to change in that space. And certainly the advancements in research over the recent years have been huge and give us a lot of hope for the future. And I know that Andy will touch on some of those today in his webinar. And now it's my pleasure to introduce Associate Professor Andy Redfern. Andy has a wealth of knowledge and expertise in this field of metastatic breast cancer. He is an Associate Professor of Medical Oncology at the University of Western Australia. He is an Associate Director of Clinical Strategy at the Harry Perkins Institute of Medical Research. He's a Consultant Medical Oncologist at Fiona Stanley Hospital. He is the Chief Medical Advisor of Linear Clinical Research, specialising in early phase human trials. He's a member of the WA Aboriginal Cancer Collaborative, and he's on the scientific advisory boards for the Cancer Council of WA, the Australasian Breast Cancer Trials Group, and the Breast International Group. As well as his professional accomplishments, Andy has a number of other skills and talents, which are possibly less well known, but definitely worth a mention. He's also been a captain of an A-grade rugby team in the past. He has a black belt in Taekwondo and has been known to juggle fire in his spare time. So no end to his skills and talents. And without further ado, I will hand over to Andy for his presentation. Thank you very much.
Thanks very much, Melanie. And thanks to Breast Cancer Care WA for the invitation to speak to you today, and also thanks to yourselves for giving up your time to come and listen. In question time, I certainly encourage questions. I'll try and pause at maybe about 3 convenient points during the presentation, as it can be hard to remember your questions right at the end sometimes, and we'll get to as many as we can. In terms of address, I go by Andy. Only my mother calls me Associate Professor Redfern, and only when I'm in trouble, as in the sentence, "What time of day do you call this to be arriving, Professor Redfern?" And I'll also show a little bit of reference to some of those other sideline activities to illustrate points as well. So today we're talking about metastatic breast cancer, and as Melanie said, there's a lot of focus, and a lot of the breast care nurses are all focused very much on early disease, and thankfully the majority of breast cancer patients, usually above 90%, present with early disease of breast cancer, but there are still a large number of people who are living with metastatic breast cancer in Australia, and thankfully that number has thankfully increased, not so much because it's more common for it to happen, as that people live a lot longer with this disease and so need more help to manage it. I hope you appreciate the style of this book thing, because it took me ages to get going, and after the initial illustration, it's all downhill on the slides from here. Just to talk about the contents and some of the sort of subjects that I put in, usually decided on through other events and through discussion with my own patients, and I have about 500 breast cancer patients I look after in various stages of the disease. Firstly, prognosis. That's always a question that's a lot of people don't ask, and we certainly don't force prognosis on people. It's like life. Life has a variety of prognoses as well. That's how long does somebody have, and we just don't know, as we'll come to. But we can make certain estimates and say certain things that may be useful to a person. How do we know the best treatment? This is quite a big section, as obviously giving people the best prognosis often these days involves quite a bit of treatment, but not all treatments work for all people, and we try and pick out the ones that are going to give people least trouble and best value. A couple of more specifics. There's been a lot of talk about immunotherapy in lots of other cancers, and breast cancer, although it has a vast array of treatment options in other areas, tend to be the poor cousin regarding immunotherapy, but that's now starting to come of age, and we're starting to get some runs on the board there, and I'll talk a little bit about that. The other side of all the treatments that are funded in Australia or on access schemes where they're provided free of charge or at some cost, people often wonder, well, if I was ridiculously wealthy and had all the money in the world, could I pay for better treatment? And I'll talk a little bit about what's available and what is not without payment. A little bit about clinical trials, and really a lot of this talk is around about the types of breast cancer treatment and so on, but I'll talk a little bit about clinical trials and whether you should consider them if you're offered them and so on. People also, obviously, it's great to be proactive, and we are, to a certain extent, the gatekeepers of drugs, and we'll advise on lifestyle, but there are lots of different things that are said about breast cancer, some true, some untrue, and many just not known about lifestyle, diet, exercise, and whether they may be useful. I'll try and talk about those. What about alternative treatments? We obviously don't have everything available, don't recommend everything, and there are a lot of things we don't have information on. So should you play both sides of the fence and consider alternative treatments? Moving towards the end, sort of talking to your oncologist. Everybody who's got metastatic breast cancer living with it will generally have an oncologist. You're not absolutely obliged to, but most people will have. It's good to have one to, regardless of your choice of path, to update you on information and what's available. And then I'll answer any final questions at the end there also. I seem to be stalled. Hopefully that's, there we go. And then, yes, finally, when is it okay to stop treatment? Metastatic breast cancer can seem like an endless conveyor belt of moving from one treatment to the other, and are breaks possible? And what happens if you decide you don't want any more treatment, and so on? And I'll talk a little bit about that finally. So moving to prognosis, how long do I have? And it really is, the crystal ball is relevant to this because we don't know for any one person. But we can say certain things, though. We can say some things. We can give an average survival time for a similar group of people. And the average means if we take 100 people we're talking to, then the middle person, the 50th person, that will be their amount of time. And then, 49 and a bit percent will be shorter, and 49 a bit percent will be longer. So it gives a rough idea, but it certainly doesn't give a personal idea for that person. So if your the average survival for a condition is 3 years or 6 years or whatever it may be, that means the middle person and half the people will be shorter and longer, but it's better than no idea at all. We can give a worst case scenario, and I think it's good to know if treatment isn't useful and it turns out to be a more aggressive form of metastatic breast cancer. What's the worst case scenario? Because it's good to get things done that you absolutely want to get done, so you've got that security, knowledge, and relaxation of knowing that anything you particularly needed to get done, you have done. The average survival time gives you some general planning, and we also have best case scenarios. And most forms of metastatic breast cancer now, it may be many years of survival. The other thing is we don't know when we have somebody sitting in front of us who's just developed metastatic breast cancer, are they that middle person? Are they that person where things will be shorter and we won't have much success with treatment, or is everything going to work and really breast cancer is not going to shorten their life? And we can also give estimates of achieving certain things. There may be weddings, there may be births of children or grandchildren usually, and holidays and other activities. And it's something to touch on that we don't try and prolong your life so we can treat you more. We treat you more so you can live. So we're treating so you can live rather than having you live so we can treat. So we certainly try and incorporate people being able to do everything they want to do alongside treatment. We can also say more as time goes by. When somebody maybe has had breast cancer in the past, or they're coming for the first time, we may do a scan or examine a lump or a bump, and we have an idea, and we do a sample, usually a biopsy, and it shows that it's metastatic breast cancer. We don't know if it's the first time, how quickly that's going. It may have been there for many years if it's something that was found accidentally, and in fact it may be many years before we had to do anything even. It may be, however, that it's moving very quickly, and it's like a photo of a running man. You can't absolutely tell how fast that man is running, and therefore when we start to do tests over the initial few months, when we have a second scan, some blood tests and so on, we may find that it's a slow moving man and not much has happened in the first 3 to 6 months, or it may be a faster moving man and that things are moving a little bit quicker. So we do get to know more as we see more test results come in. So time gives us some ideas. One thing to say that limits this a little bit is we don't wait to see if it's a fast growing thing or a slow growing thing. We usually recommend some kind of working towards treatment starting, and if treatment's successful, we may not have full information about how fast that man was going because we've stopped the man from running. With metastatic breast cancer, one of the things that guides us, we've talked about an average, and some people it may be shorter as a worst case scenario, but some people it may be many, many years. What does it depend upon? And on the right here, you see some information tools. I've been involved a little bit in helping develop some of these, like Hope and Hurdles from Breast Cancer Network, and the Cancer Council has a document that involves metastatic breast cancer also. And these have been developed because we realize that people with metastatic breast cancer have left a little bit out in the cold from the point of view of getting good information. And so these are good resources that will tell you some of these things. So if, for example, the cancer comes back quite quickly after lots of initial treatment within a few months, then that tends to be that it's the faster running man. Doesn't mean that there won't be a number of years of survival. It makes it a bit less likely. Whereas if it's been many years since the cancer, it tends to be a longer time on average. How much cancer is present? If it's a tiny little bit, we may be able to give it some local radiotherapy and start some treatment. And certain areas, such as the bone, are a bit easier to treat and control for longer on average than other areas. However, I have people who had liver secondaries and lung secondaries are still reached a decade now with full control of the disease. So there's no absolutes, but whether there's a small volume and whether it's in one spot, it on average makes a difference. People worry sometimes, I've noticed in my practice, and one can understand why, if they've got a new spot on a scan and we're having to change treatment, that it's in the bone and the lung, let's say, or bone and lymph node versus just bone, and they're worried this is a big event that makes a big difference. It doesn't tend to make a big difference. The exact number of spots are involved. It's more how treatment does for them that guides how people do. So how much is present and where is some guide, but it's certainly not a big concern to us if there's a new spot or a new site. A big one that does guide, however, is how well initial treatment works. As now with metastatic breast cancer, we're able to prolong life considerably with treatments, but some people get a great result from treatment, and some people it's less effective. And so how well initial and future treatments works tends to guide things quite a lot. How many suitable treatments there are also is a factor. Traditionally, in the past, triple negative breast cancers had less treatments, let's say, than the ER positive and HER2 positive breast cancer. And I'll talk a little bit about the specifics coming up. But thankfully, recently we've had an expansion of possibilities for the triple negative customers, and that's now evolving. And for a lot of people with breast cancer, I have many people now with metastatic breast cancer on treatments now that didn't exist when they were first diagnosed. The initial treatments took care of the disease to the extent that now they're need further treatment some years later, and we have new things we just didn't have. So there's probably many people online that you may be getting a treatment in due course that doesn't yet exist at the moment or is not yet proven. And that's really talking to that whether new treatments appear, and it's almost invariable if we get good control with the earlier treatments, there will be new treatments at the later stages. General health motivation and support also does help, and people talk about a positive outlook and a positive attitude. Now, first thing to say is that having a positive attitude, well, you feel better already. So compared to people don't necessarily choose their attitude. That's part of one's native persona as to how one reacts to adversity, but certainly being positive makes you feel better. It certainly doesn't hurt, and people are usually more enthusiastic. It's certainly been shown that people get a little bit less side effects if they have a positive outlook on things as well. So people tend to get through treatment more easily with a positive outlook, feel better. There haven't been good studies because it's very hard to study a positive versus a more negative or pessimistic outlook on survival, but certainly we too tend to give people the reassurance and general information and motivation to do that. General health is also important, as we'll come to as well. People are living for many years. In fact, I have some people who may die naturally of other causes many years after starting with metastatic breast cancer. And so looking after yourself is also important. And the support of family and friends firstly improves quality of life vastly, helps you get through treatment, and provides positive life experience, and may also impact on eventual outcome also. But again, very hard to randomize and take away people's support or give people support. Obviously, you can't compare them and it wouldn't be appropriate to do so. We just try and get everybody support where they don't have it. The final thing to mention is about lightning bolts, and that's a little bit about looking after yourself. When you have any kind of cancer that's present, as metastatic breast cancer is to some extent, maybe fully controlled and really not causing many problems, it does make things can happen, complications of the illness that are not about it growing, but it can cause blood clots, it may cause damage to nerves, things of this nature that are not about it generally growing, but put you at risk of an event. And that's in that worst case scenario that you're a little bit more likely to have lightning bolts, to get infections or things like that. But it's certainly not a deal breaker. Many people, we manage to avoid these things, but keeping an eye out for extra things and letting your general medical team, both your family doctor and your oncologist, know if you're concerned about anything is always good. And this is a slightly glib look at that. Things I have. It's almost I've done my job in that I have an increasing number of people who die many years after getting breast cancer, and we all die eventually, obviously, from not breast cancer, from heart disease or things like that. And we try and watch for those other illnesses as we go, as people start to live longer and longer. So certainly, we none of us know how long we've got, and I may, as the classic is being hit by a bus. And this is a look at what things we do have to worry about. We all worry, I guess, a little bit about shark attack in Australia, even though it's far more dangerous to drive to the beach than it is to go swimming on the beach. But we don't worry about the journey there. And in the US, this is a slightly bizarre look at those kind of things that can happen and being careful. Apparently 10,000 people a year suffocate in bed through bedclothes. Powered lawnmower accidents, 1,000. Camping accidents, I don't know, 166, and it gets strange. But texting and walking, we do have to be mindful of texting, and we can no longer drive and text. 120 people die due to texting and walking. And then getting to those unsure what happened. Knitting accidents counts for 7 people a year in the US. And blogging incidents, I guess we're all sort of blogging at the moment, 2 people a year. But it's certainly with metastatic breast cancer, it's good not to be fatalistic and take care of oneself and look out for various things. Moving back to that survival and therapy, and obviously, as doctors, the thing we can do is provide people with reassurance, information, support, improve their general access to services and so on. But we do a lot of therapy as oncologists. I've been treating people since 1991, so 33 years, 2/3 of my life, I guess. Doing breast cancer research for a bit longer than that. So 88, I started that. So I've been doing it a lot, and I've seen these building blocks to therapy that extends life added to extensively over my time in the area. Some of the things about therapy in metastatic breast cancer. Firstly, single drugs probably tend to work just as well as combinations. So it's relatively rare that some big and toxic combination of drugs is better than giving them one at a time. And so chemotherapies combined have not been found in trials to prolong people's lives. It may slightly increase the risk of sort of the chance of shrinkage, but actually you've then got less options and they tend to have more side effects. So actually in terms of survival and quality of life, we generally give them singly. Potentially that's not that's chemotherapies. We do give immunotherapy and chemotherapy together, but that's a different area. The chemotherapies we use, if you're just getting metastatic breast cancer and you had some preventative chemotherapy because you had early breast cancer, they tend to be easier going. In stopping early breast cancer, optimizing the cure rate at the beginning, we give they're slightly more toxic drugs because they've been around for longer because they've got through the trials of metastatic breast cancer and they've been tested in early breast cancer very thoroughly. They tend to be somewhat more toxic, but they're only given for a limited period. And so the general concept is that we can ask people to go through more side effects if the goal is eventual cure. Now, it's not that we're not hoping to give people very long-term survival in metastatic breast cancer, but we found that being really intensive doesn't actually increase the chance of longer-term results. So we can actually go a bit easier than for earlier breast cancer. And the drugs are later, more recent drugs, and they tend to have less side effects. So if you're just going into new chemotherapy, don't be too disheartened. You're going back into that treatment that you had at the beginning because it's usually different and usually easier. More of the chemotherapies in that space are tablets, or things like the capecitabine drug or vinorelbine, which are tablets as well, and tend to have that gamut of so much nausea, so much hair loss, and so on. We're also getting into the realm now where we can finally, after it was first discussed in 1900, and I'll come back to this, we can now add bits onto our chemo that take them to the cancer only, and so they're targeted. And that's enabling us to give high dose of chemo to the cancer, but lessen the side effects elsewhere, and I'll come back to that. The other sort of getting towards the end of these themes of how treatment works as a general thing, the pack from Breast Cancer Network is called Hope and Hurdles, and that's because metastatic breast cancer treatment, you start a new treatment, may work very well, and that's great news, obviously, and we're certainly very happy with that. And that may go for a long time, and that's the hope that comes into realization of longer, good quality of life usually. But then for most people, over a certain time, that may be months, it can be a small number of years, that treatment will lose its control ability and will see the cancer increase, and that's a new hurdle, and then people change to a new treatment. I've learned over my number of years doing this that switching treatments is not necessarily the very first sign of growth. So if a scan's slightly increased or a tumor marker's slightly gone up, that it's probably not the right thing to do to go, oh, well, we need to change quickly because that'll make a difference. Actually, if the disease is 95% controlled and it's moving pretty slowly, we may get even a 6 months or another year out of that treatment before changing it, and that person may be very well. And if we change immediately, then we may lose that time of control. And so though we certainly don't want to go till people are getting too sick or can't have new treatments, that's where the science is left behind. It's almost the art, because there are no trials to tell for an individual when the light times changes. It's between yourself, how you're feeling, your oncologist, how they feel things are going, and so on. So it may not be necessary to change immediately if things are not quite 100% controlled. And that's because the total sum of lifespan really is the sum of the shorter periods of control on each treatment. And obviously we try and make each of these building blocks as long as possible and as low on side effects as possible. A topic that I've added in compared to the last time I gave this talk in a different version is that of liquid biopsy. Liquid biopsy, this is talking about these blood tests that you can have done, and they can detect the sort of the presence of cancer cells or cancer chemicals, the activity, how active the cancer might be, depending on how many cells there are. And you can also tell from the nature of the cells a little bit whether the cancer is changing its behavior and whether different treatments might be appropriate. And you can do it with the blood rather than needing to take a sample, which can be painful or cause side effects from the actual cancer itself. And so these are all grouped together. There's many different types called liquid biopsy. Now, it's been an area of promise for 50 years, and I've actually done a lot of research, probably for 15 to 20 years on this. And I have to say, we've not quite got there with it yet. You can pay for these assays. You can pay to have your blood taken and your circulating tumor cells tested. And this is measuring actual tumor cells in the blood. And one might anticipate that that'll be very useful. If there are less tumor cells or no tumor cells, that's presumptively better than a few or lot. The other one that's done a lot is the looking for tumor DNA compared to your normal DNA in the bloodstream, and a measure of the presence of the tumor and also a little bit about its behavior, because the DNA changes over time and a tumor may cause the cancer's behavior to change. At this stage, though, we have not got any evidence that doing these tests and changing treatments, which is mostly what we're looking at in metastatic breast cancer, should we be changing now or not? We've not yet found that measuring circulating tumor cells or DNA when it starts to go up is a good guide to changing treatment, and that's why they're not funded on the public system. If we had a one showing, yes, if you saw one of these tests go up and you change treatment now, rather than waiting till CT scans or other things show a change and people live longer or get less problems with the cancer. We've done a couple of those trials and they've not yet shown that it made any difference. We are doing a little bit of the ctDNA one, and we do a little bit of that. We started to do a little bit of that connected with trials or funded in very specific circumstances, as certain DNA changes do suggest that particular treatments may be useful. And we're at the beginning of that moving into our everyday practice. So I might pause briefly there and ask for any initial questions because this treatment, how do we know what best treatment to give? Obviously, a lot of managing treatment is based on the treatments we give and how well they work. So I might pause there. I'll stop sharing screen briefly because I might regret it, but hopefully not, because I can't see questions otherwise. So are there any questions as yet? I'll have a look at the chat. Right. So Petter's asked, prognosis is so varied and has so many dependabilities. How do we see this affecting someone wanting to access life insurance? Is there a way to approach your treating team with this question, especially when you're responding to treatment? And that's a great question. Look, there is life insurance, and then there's also accessing super. And we certainly, my philosophical and medical view is basically it's your money, you have the right to that money, and I'm very happy to be pessimistic in filling in these forms, as there are those lightning strikes, and as we don't know what somebody's prognosis may be. I'm very happy to put somebody and to be classed as terminal. I think for your super, you have to be within you have to have a prognosis of less than 2 years. I'm very happy. I always tell my patients, actually, I'm way more optimistic than this. I'm happy to fill in a form that says there is a solid chance you may have less than 2 years to access super. It's your money in any case, and you want to be using it now when you want to use it. And so there is a chance that it may be less than 2 years. So I'm entirely happy as a person's treating doctor to fill in the forms so that people get access to those funds. Certainly approach your treating team and talk to them about it, but I think most treatment people are very much on the same page. We won't want to say no, we think it'll be longer than that, and then people do have one of those lightning strikes, and it's basically your money, your rights to it through insurance in any case. Monica has asked a question: is liquid biopsy the same blood they pay to send to the US to see if someone should have chemo or not in breast cancer? That's not the same, though. Though there are many different iterations of this test, and there are private companies that will take your money and do a test and give you a comprehensive report on many different things. The commonest test that looks at whether you should have chemo or not is called the Oncotype DX test. That's done on tissue but not extra tissue, and they can send a little bit of your cancer away that's already been taken and test for that. That costs about $5,000, and that is a test that if somebody's got an estrogen sensitive cancer in the early setting, it says should you have a bit of chemo as well as your hormones, or are you good with just hormones. There are some evolving blood tests trying to tell the same thing that are less advanced, and there are a couple on the market but not been proven to have the same prediction as that tissue test. There are tests you can do that look for CTCs and test lots of chemotherapies in a test tube or in a petri dish and see which chemos kill the cancer cells, and then recommend the most sensitive chemotherapies that cancer is sensitive to. Many of those tests, I have to say, those tests use a circulating tumor test called Cell Search, which is the best validated one, and we use that in our research. And when we take people with early breast cancer, we only find about 3 or 4 out of 10 people have visible cells, and there are very small numbers of cells. We're looking at we're looking at in a Telmore tube, a positive test is 1 cell and a strongly positive test is 10 cells. So there's so few cells. These companies always seem to come up with enough cells to test about 50 different things. I'm always a little bit suspicious, I have to say, as to whether they're really finding tumor cells, as we are, experts in this research field, and we even put tumor cells from cell culture deliberately into blood in the test tube to check that our assay is working, and we find it almost always works. So I think some of those blood tests looking for circulating tumor cells, they may be finding false positives and they're not really testing tumor cells. The other thing is that there isn't a validation. It sounds a great idea, testing in a test tube, different chemos on tumor cells, but we find when tumor cells are in a ball or in an animal or in a person, they respond to completely different treatments because the immune system and the packing tissue around change how the cancers behave. And so we found that those tests are not quite so don't give us the same results as what we see when we give them to people. So we still tend to give the statistically best things that got the best hit rate rather than tailor it yet, but maybe in the future we will. So I think microphones are disabled. It is coming down to the chat, but I'll give the treatment part, which is the longest bit, and if anybody has any questions, we can pause again for that. And we'll just do some more sharing and get back into the okay, so therapy, how do we know what the best treatment is? This apothecary shelf shows our breast cancer armamentarium is getting to be a bit like this, and we're almost spoilt for choice. And it's not, how do we find new treatments, as how do we choose between the ones we've got initially also. First thing to mention is, as I'm sure most people are aware, is that breast cancer is not a litter of all the same breed. There are different subtypes. It's always good to put puppies in. You can't fail to put puppy photos in any presentation, I find. And obviously, breast cancer is very much like the range of breeds of dog, and they have different behaviors, tendencies, and so on. For breast cancer, there are many ways you can dice up the biology of the disease to put it into groups, but certainly very robustly. There are ones that are sensitive to the female hormone estrogen, made by the ovaries and made by other tissues in postmenopausal women. And they are sensitive to anti-estrogen drugs, blocking estrogen. There are HER2 positive cancers, and that's another growth system, and I'll talk a little bit about what that is, though many people know a bit about it already. HER2 positive cancers used to be the most aggressive and hardest to treat, but we have changed that, as I'll show you. And then triple negative breast cancers, which then became the hardest to treat, but we're certainly making some mileage there also. You can also, somewhat confusingly, these aren't exclusive. You can have a estrogen sensitive and HER2 positive cancer. So some people have both of those behaviors in the cancer, and it means we can potentially use both types of treatment. And I'm going to talk a little bit about each of those, though some of these treatments do cross those boundaries. So sort of shedding light firstly on estrogen control cancers. That's about 70% of all breast cancers are estrogen controlled, and in the metastatic setting, it's about 60%. So very common. Now, certainly in our initial concept was that estrogen growth was a single pathway. There's this hormone estrogen, and it drove growth, and you could block estrogen and your problems were over. And this treatment started in the it was in 1896, the first Glasgow surgeon published some work, and he was removing ovaries in women, and finding that the first woman he tested was a young woman who'd developed locally advanced breast cancer just after pregnancy, and he had done a PhD working with controlling milk production in cows, and noticed that breast tissue shrank in cows when their ovaries were removed and milk production stopped. He thought, well, maybe it's also good for stopping breast cancer, and he removed this young woman's ovaries, and she had an amazing response. And then he did the same for a number of other women. If that first lady had had an estrogen receptor negative breast cancer, he might have thought, well, that didn't work, and then it might have been another 50 years even before we started to do this. But so it's certainly been around for a long time. We have learned that for some people this is the case. I have a lady who's now been 22 years with metastatic breast cancer on just a hormone blocker, and her breast cancer clearly does look like this. But for the majority, and this is the sort of the signaling pathway. I'm not going to get too much into fancy biology, but we need to work out these things before we start developing new drugs. And this is estrogen at the top. This is English spelling, as I'm English. The Americans don't like the O, but same hormone. This is the estrogen receptor, ER, and this sits inside the cell. So the estrogen has to get into the cell through the plasma membrane skin. It sticks to the estrogen receptor, and then it switches on a load of genes in the DNA, which cause growth and increasing the numbers of the cancer cells and increasing survival of the cancer cells against some other treatments as well. So this is a bad thing for the estrogen is making breast cancers grow. And we block estrogen with drugs, making estrogen with drugs like the aromatase inhibitors. So that's there's anastrozole and letrozole and exemestane, which have each got their own trade names. We can also give a drug that sticks to the estrogen receptor and stop estrogen getting to it, and that's what tamoxifen does, as well as fulvestrant, also called Faslodex. And we can also stop estrogen being made if you're premenopausal with those injections you have to have under the skin, like goserelin or Zoladex, also called, which stop estrogen being made. And these are do very well. And for a metastatic ER positive breast cancer, on a whole, anti-estrogen drugs control the disease for a bit over a year for the average person. But like my lady, she's had 22 years, so she's at that good end of the spectrum. We have learned, though, for many breast cancers, this is what the road looks like, the signalling pathway to growth. So we're moving from Perth, unfortunately, to the Sydney traffic system, and most people have got more commonly a Sydney signalling pathway than a Perth one. And this has meant that to get the best results, we can't just block estrogen, but we have to start blocking numerous other roads. It's like the freeway into town. If you block the freeway, then cars start to look at their Google Maps and start to take other routes, and they take more minor roads, and then traffic is restored to the center. And it's like that for growth. Cancer cells are blocked and don't know what to do initially, and many die, and then they start to work out other routes. And so we've found that actually this pretty simple cartoon, and this is alarming for my trainee doctors, never mind for people not working in the field, looks kind of like this. And we are starting to, and we've now got drugs that block things like PI3 kinase, this one here, AKT, this one here, and various other drugs in these pathways. I'll move quickly on from that because it's very alarming looking, but we are starting to address this and block those multiple roads. And this is given new drugs, which tend to be very targeted and have good side effect profiles, as we call it too. These are just some of the names of those proteins, a bit like the estrogen receptor. And these are some of the drugs. Some of these are now being used. Everolimus, for example, is being used, and telacillib is being used also for certain molecules. How good are the results for these things? How much extra time do they give you? Well, this is what our trials show, and I'll quickly simplify this. This is the extra time people get. Everolimus gives people 4 years of extra survival. HER2, 4 months of extra survival, 6 months for HER2 targeting, 15 months for CDK4/6 inhibitors. So many people with estrogen receptor positive breast cancer will be on those, and PI3 kinase inhibitors. The initial study, 8 months, though. More recent studies have not been quite so promising. And if you have a cancer that's suitable for all of these, if you have an ER positive and HER2 positive breast cancer, you may benefit from several of them. And so these are all adding the building bricks to lifespan. So that's the thing that's particular to ER positive breast cancer. The first line treatment, we're giving one of those CDK4/6 inhibitors, and many people be on one of those as well as an anti-estrogen. And then after that, there are several combinations we're starting to use. Moving to HER2 positive breast cancers, and these have got a chemical protein not inside the cell, but on the outside that picks up growth signals and makes the cancer grow. And this is the bit of a similar diagram. This is the inside and the outside the cell. This is the skin of the cell, call it the plasma membrane. ER sits in here, so estrogen has to get in here, whereas HER2 is on the outside of the cell, and it detects passing growth signals and makes the cancers grow. So we get these growth factors that stick to the outside of the receptor and cause the cancer to grow, divide, and do other things we certainly do not want it to do. And this has been the real poster child for kind of personalized treatment, I think, across medicine, never mind cancer. And trastuzumab, better known as Herceptin, its trade name or its initial trade name, is an antibody, and this targets this receptor and switches off growth. This is even the subject of a Hollywood movie called In Living Proof, where Halley Connick Jr. played the oncologist, which would be myself. Though Dennis Slayman, I know slightly, and he's the famous oncologist, the celebrity oncologist that found this molecule and also developed this treatment. We find that Herceptin has made a huge difference. Firstly, it can cure many people with early HER2 positive breast cancer, and it can actually prolong the lives of those people with metastatic disease. And it can even provide very long time cure just by itself. I have a patient now 12 years on Herceptin. 14 years now, just past. She's my longest running patient, as we've only had these drugs for a certain amount of time. For the majority of people, though Herceptin is prolonging life substantially, we do find that most people's cancers work a way around, again, that extra growth pathways, and growth signal is restored. And we've now developed extra HER2 drugs. Lapatinib is a tablet drug that's another HER2 blocker. We've got another blocker, Perjeta or pertuzumab, that's now given with Herceptin. Many people with HER2 positive breast cancer will be on Perjeta and Herceptin. And we've also we talked about smart chemos, we can target chemos. This started with HER2 positive breast cancer, and the first one was a drug called TDM1, and this is Herceptin with a chemo stuck to it, so the chemo only goes to HER2 positive breast cancer and not your normal cells. And so we're now starting to build combinations of these that give better and better results. And just to show you how we're doing with HER2 positive breast cancer, back in 1990, and that's when I started as a junior doctor, we were just giving some basic chemotherapies, and the average survival was 11 months. By the time I was a registrar, we were giving taxanes. These are chemos from Utrees, and it had already added about 50% to lifespan. It was about 17 months. 2005 was the initial approval of trastuzumab, though I was involved in the late 90s in the early trials of it, and trastuzumab was almost doubling survival out to 31 months. It's 2.5 years from a year. Pertuzumab, that second antibody, we combined with trastuzumab, and we were amazed that giving 2 antibodies rather than 1 made this huge difference. And this is now the standard of treatment in Australia. You get pertuzumab and trastuzumab with chemo, and the average survival from those trials, and this trial was started in 2015, is 57 months. But we do have some new stuff on top of that, and there's going back briefly, you'll see there's an extra tunnel there, and I'll tell you what that tunnel is now. So the magic bullet, and this is targeted chemotherapy. The whole body's bathed in chemo when we drip in standard chemo in. All the cells may get exposed. Cancer cells are more sensitive to it than normal cells, but some normal cells are affected. We've got hair loss, we've got low immune cells, we've got sore mouth and diarrhea and so on. And so we're looking at trying to deliver the chemo only to the cancer. TDM1 was our first magic bullet, really the first to be used widely in medicine for anything at all. This purple thing is the antibody, that Herceptin that goes to the HER2 protein on the outside the cells. But it's now got these yellow spiky balls, which are chemotherapy. And the technical bit, we had chemos and we had antibodies decades ago, but to try and get them to stick on and to stay on in the bloodstream, but just drop off in cells, took many, many years of research. And we now have these linkers, which mean that the drug touches the outside of the cancer cell. The cancer cell then takes the protein in, the chemo drops off in the cell, and it kills the cancer cell. So TDM1 we've been working with, and I'll show you how that's going in a minute. And we've now got newer ones, which I'll also talk about shortly. We have been working to make this better. As a researcher, we've got a great drug that's been doing really well for people. We want to know what's the next thing. We'll use that very happily, and we'll try and better it. So we've been looking at stronger chemotherapies or better chemotherapies attached. We've been looking at more chemotherapy on an antibody molecule to increase the cancer cell dose. And we've even been looking at 2 antibodies to target cancer cells even more specifically with a chemo attached. And there are now 2 chemos we're using, and Kadcyla is the old one, the TDM1, and this is shrinkage rate of cancers compared to old-fashioned chemo. We're seeing the chemotherapy, it was about 3 in 10 people got shrinkage. It went up to about 4 in 10 people got shrinkage with the old magic bullet, Kadcyla. Try and get my slides going again. We now have a new magic bullet, Enhertu, or trastuzumab deruxtecan, to give it this really long name. And Enhertu is now available for HER2 positive women, and that gives about a 9 out of 10 shrinkage rate. So we got a bit better, and now we've got loads better with Kadcyla, with Enhertu. Obviously, we want to know about survival. We haven't got information out past 2 years for Enhertu, or very much, because it's very new. The survival at 2 years, which is what we can compare for old chemo, went from 5 out of 10 people to about 7 out of 10. And now it's about 8 out of 10 for the new magic bullet. Very early results. And so now in Australia, people are getting the new magic bullet, not the old one. And I guess at how long survival might be as an average from that is we might be looking at now past 5 years and even up to 6 years and that's the average person. So that's where we're up to with HER2 positive cancers. And then finally, I'll touch on, last but not least, the triple negative cancers. And these are really called triple negative because they don't have estrogen or progesterone, which is a related hormone receptor. They don't have HER2. So those 3 things are negative. So it's really triple negative is a diagnosis of ignorance. It's got 3 things that we know about that aren't there. But there are many things that may be there that help us to target these cancers. So for triple negative breast cancer, and it was mentioned that I'm a fire breather. If there's anybody from social services present, this is not my 16-year-old son on his 16th birthday doing some fire breathing. But if you're not from social services, that's kind of my son learning to fire breathe, and that's me obviously supervising in a responsible way. But obviously, chemotherapy is very much like fire. It's very unselective, and some things are more fire retardant than others. 16-year-old son's not so much, so you do have to target it a bit, but there is collateral damage. So giving chemotherapy tends to be affecting very usual systems in cells that's not very specific. However, when this is the tip of the sort of the biological iceberg, if you will, for a breast cancer cell. Estrogen, progesterone, and HER2 is what we've been looking at for many years. But the breast cancer cells are much more complex than that. There's a lot below the waterline of what we don't look at standardly in all these 3 things, some of which you'll have heard of: prolactin, important in breastfeeding, vitamin D, insulin, relevant to diabetes, growth hormone, thyroid hormones, and so on. There are, when we look at a breast cancer cell, and this is a electron microscope picture of a breast cancer cell, when we measure the percentage of breast cancers, triple negative ones that have other receptors on, you see that many of them have very frequently got other things that might be useful to us. And we're now starting to look for positives in triple negative we can target. And this, coming to Taekwondo, obviously here we have some normal cells. Here we have a cancer cell, and this is my then I think 13-year-old son Cameron, this was his exam for his black belt, and what you have to do is break the board without affecting the normal cells. This is him in motion, and you also want to affect her landing so you don't damage yourself as well. And he managed that there. And he now has a black belt also, though he's now a few years on and he's now doing cancer research. He's working with me, which is very nice, prior to going on and doing an advanced science degree. And obviously, this is what we're trying to affect in triple negative breast cancer. We're looking for things that can, those targets that board in triple negative breast cancer. And so we've done lots of fancy biology, and we've managed to divide it almost into too many different parts of the pie. And these are some of those names. You'll see some of them are very immune dependent. Some of them, the skin chemicals that may make them grow. Some of them, their DNA repair. They've got damaged DNA, and we may be able to target that. And each of these gives us a clue as some treatment. And I apologize, some of these are quite complex names, but these are drugs we're using in other areas, and this may guide us to what may be useful in triple negative. I'm going to give you a couple of examples of where we've got to with triple negative for some of these, trying to find other pathways we can target. This one, EGFR, is something that's important in skin health, and we can also target it in skin cancers and some other cancers, and it may be there in triple negative breast cancer. Some triple negative breast cancers also have the detector for the male hormone testosterone, and so when that's present, we've been using anti-testosterone drugs. Just to bring you right up to date, we've actually been a little bit disappointed. We've seen some positive results. This is the anti-skin healing treatment, the EGFR blocker. We give an antibody called cetuximab. It's a bit like Herceptin, but it hits EGFR. We found that the shrinkage rate doubled, so we're happy with that. That's an advance, not many small side effects. And we did increase the control period. Now, 1.5 to 3.5 months isn't very long, but these patients have very many chemos already, so they're quite a long way on. Survival improved by 3 months, and we're trying to work on this to better select patients who may most benefit, to see if there's a group of people who may treat standardly. We're not using that standardly as still, it's relatively short benefits, and there are some side effects. It can cause diarrhea, it can give you a sore mouth, it can give you a skin rash, and people do get allergies to the antibody also. So we're working on really who does really benefit from this one. And the second one, anti-testosterone treatment. This is a study where we looked at 400 people with triple negative breast cancer, but they had this testosterone detector on. In 12%, so only about 45 or so. Some people, we felt they weren't suitable for treatment. They needed something quite quickly, and so they were treated. The average time on the drug was a bit disappointing, but we did see about 1 in 5 got some improvement or control despite the AR. So we're working on how to better work that out. Side effects, well, this is a bit of a glib look at it, really. Certainly, women did notice that they on anti-testosterone treatments, because too much testosterone obviously gives you your that silly male behavior. People felt a bit tired and a bit like less doing things on anti-testosterone treatment, and they were a little bit less likely to watch sport, though sensibly, I'm not a sport watcher. Women were less likely to work on the engine or watch sport as well. Generally, side effects well tolerated, but there were some fatigue and a bit less drive. So in triple negative, we've trying to find a receptor that's magically successful, like ER and HER2. We've not been successful. We've seen some small gains. And I think we've decided in those receptors, we have to think about the big picture and look at more complexity. This is a very cool thing. You may have seen this if you've been down to Frio when it was up. I was noticing around Frio, there were these bits and bobs of buildings that have bits of yellow on them. And it seems strange, but clearly deliberate. And then I found out that if you went and this is like breast cancer, we might see a AR positive, EGFR negative. We might have insulin receptors are there and so on. If you put it all together, you get a picture. And so we may have to look at more complex kind of signaling pathways in breast cancer to work out how to treat them better. And we're looking at not just 3 molecules or just 4, but we're looking at in research measuring lots of molecules, looking at lots of different cells. And this is a breast cancer with different chemicals lining up different types of cell. And this is my friend and colleague Al Forrest, who's the scientific director of Perkins. And he's one of these guys that's very clever and can put together all this information and maybe come up with a signature of lots of different pathways intertwining to say you should have this drug and this drug for your personal breast cancer. So this is that true personalization. And I think for triple negative breast cancer for targets, we're going to have to do that. That doesn't mean that we haven't got things, though, that are new for triple negative breast cancer. And that brings us, and I'll pause for questions after this immunotherapy chapter, and that brings me to immunotherapy. Immunotherapy in oncology generally has been really amazing in things like melanoma. And we had the 10-year survival results for our initial combined immunotherapy trial for melanoma. And 10-year survival on chemotherapy was 3%. And on immunotherapy, 10-year survival is 52% for advanced melanoma, which is just amazing. And some of those people in that 48% that are not alive at 10 years have just died of natural causes and not their melanoma. So that's the poster child. We're trying to make immunotherapy work just as well for people with breast cancer. And immunotherapy, how does it work? Just briefly, many things are called immunotherapy, and there are certain things, certain dietary supplements you can take that potentially are said to boost your immune system. What we're talking about, these are immune cells, lymphocytes jumping on a breast cancer under the electron microscope. And it's really revealing breast cancer cells. It's removing that invisibility cloak and showing this breast cancer cell to the immune system. For those that are interested in a little bit of technical detail, this is for you. For those that are not so much, I apologize and don't worry too much about it. But this is a cancer cell. It might be a melanoma cell, might be a breast cancer cell. And our immune system normally should spot tumor cells. And it may be, as some of us are sitting here, maybe I've developed a tumor cell as I'm talking now. And one of my lymphocytes has gone, oh, I don't like the look of that. And it may have used this system and killed that cancer cell before I get cancer. We believe that probably does happen. It's hard to prove, but it probably does happen. It's because tumor cells, because of all the damage in their DNA, produce dodgy looking proteins that are mutated, not like our normal cells. And T cells can recognize these dodgy looking proteins called antigens, and they can then will jump on that cancer cell, as we saw in that previous picture, and kill them. However, to stop our T cells jumping on all our normal cells, if they look a little bit sus, there's also a self-recognition system, and this one's called programmed F1 or PD1, and all these immune treatments are often called PD1 inhibitors. And PD1 is the dark blue marker is on our tumor cell and a lot of our other normal cells, and our lymphocytes can also recognize a self cell. And the lymphocyte tries to come to a conclusion as to whether it should kill the cell or not. And where your immune system has failed to kill a tumor, maybe because the PD1 is stopping this brown system working. So this is just the second picture there. What we do with treatment is pretty simple, actually. We give an antibody called a PD, blocks this pairing, either the PDL1 or the PD1 half. And we got both PDL1 inhibitors and PD1 inhibitors. These are just antibodies that stick to these proteins, stop that recognition of a self cell. The lymphocytes then recognize that the tumor cell is not, shouldn't be there, and kills the cancer. This was good enough to win the Nobel Prize for Medicine about 5 years ago now, for the two guys that discovered PD1 and a second system, which we also target, called CTLA4, and they're the two main immunotherapies. So when you hear about immunotherapy given in almost any cancer, it's almost always this stuff. We were initially a bit disappointed with breast cancer because we found that melanoma had amazing shrinkage with just one of the two treatments we use. Bladder, kidney, and lung were pretty good, and breast cancer is pretty low. Though we have identified since that triple negative breast cancer is more sensitive to immunotherapy. And we can also go further and look on triple negative breast cancer cells and find this chemical pairing. And if it's present, it means that that system may be blocking immune cells from doing their work. And if you're PDL1 positive, then immunotherapy may be for you. And we now, for people with advanced triple negative breast cancer, have a drug called pembrolizumab, which is added to chemotherapy if they have this brown stuff present in their tumor. And this has added 8 months. This has added 8 months to survival for triple negative breast cancer. And we're now starting to move past 2 years with triple negative breast cancer. The final thing I'll briefly mention, we do have also for triple negative breast cancer, because many people are getting this, one of those targeted antibody drug conjugate drugs, a bit like the TDM1, which is an antibody against something on the outside of triple negative breast cancers and other breast cancers with a chemo. And we're now using a drug called govitecan or Trodelvy against triple negative breast cancer, and that is also adding a few months of survival also. So we're now past really 2 years and hoping to work towards 3 years even with triple negative breast cancer for the average survival. So I'll pause there and stop my sharing and check to see if I've got any more questions. So Kina has asked, being on trastuzumab and pertuzumab, which is that double antibody, we're always checking the heart. So will further treatments be less toxic to other organs in the body? And do we think we'll see a cure for metastatic disease in the future? So two quite different questions. I think, firstly, with the HER2 and the heart testing, the risk of a significant heart, what HER2 targeting does, we know that HER2 is evolved slightly in heart muscle health, and we know it's only about one in sort of around about 5 to 10% of women, their heart muscle function will get less strong on a HER2 targeted treatment. If we stop it, though, it goes back to normal, which is good, obviously. And what we do is we tend to stop it and give some drugs that relax the heart muscle. And we found in about 8 out of 10 people, we can restart the drug. But we obviously have to check for that heart muscle lessening. We want to do it before the heart really becomes really affected, so people start feeling unwell. It doesn't, however, seem to cause permanent heart damage. It doesn't cause heart attacks. It doesn't cause cardiac arrest, so it just causes fatigue and breathlessness that does seem to be reversible. So we do check it, but it's a relatively rare side effect. We have found for HER2 that it doesn't really matter what type of HER2 drug you're using. They're all about 5% or a little bit higher. So I think so HER2, compared to some of the side effect rates for chemotherapies, it's a very low side effect, but we'd like to have 0 side effects. I think we may find we're having to accept some really low rate of side effects like that, to be honest, to be frank. I don't think we'll get a 100% away, and I think a 5% to 10% might be almost as good as we get it. I think we'll be looking at curing more people. Will we see a cure for metastatic disease in the future? Well, that's a tricky one, because we are curing some people with metastatic disease, and we believe, like my patient who's been on estrogen blockers for 22 years now. She was 59. She's now 81, and there's no sign of cancer coming back. It was in the bones. I have a patient who has had bone and lung secondaries. She's just been on Herceptin for now approaching 14 years, and I suspect that I've had people who have stopped Herceptin on at 10 years with no activation of the tumor. And I suspect we are curing at least a small number of people. The Cleopatra study, which was the original trial that gave pertuzumab, trastuzumab, is at 8 years now, and about 30% of women are still got full control at 8 years. And of that 30-something% of people, we believe that some of those people are being cured, but it's still not the majority, unfortunately. So we are probably curing a small portion, and that is growing as we build it. Will we be able to say your chance? What we say a yes to that question is, will we be able to say your chance of curing metastatic diseases? We may be at 50% for melanoma. We might say 75% is a good chance of it. I think we will be able to do that in the future, but I think we may be, depending on the breast cancer subtype, 10 to 20 years off jumping ahead of 50%, I think. A question: what are my thoughts on cancer as a metabolic disease? That's from Kylie. Great question. There's a group of people who tried to say, what are the characteristics of cancer? What makes cancer cancer? And they call it the hallmarks of cancer, and they published it in the journal Nature, which all scientists like to publish. It's a kudos, but they're important pieces of work. And there were about 8 different behaviors, and it was things like growing non-stop without stopping, avoiding cell death mechanisms, avoiding the immune system, and things like that. There's been a recent update, and one of those is cancer as a metabolic disease. It's that cancer is reliant on the way it uses glucose, the way it uses fats and other things to survive. And so I do some work with cholesterol synthesis, and we've found that women that are on cholesterol blocking drugs, and this is not randomized, this is just we looked at people on cholesterol drugs routinely, their chance with early breast cancer of getting their cancer back seemed to almost halve if they were on one of these statin drugs, coincidentally for high cholesterol compared to those people that weren't, particularly HER2 positive cancers. And we're trying to work out what's going on there, and we may start a trial giving people who don't need it a statin for cholesterol, cholesterol lowering drug. There is also a study with metformin, and this is somewhat in the alternative space. So metformin is a bona fide anti-diabetes drug, helps you handle glucose. There was a randomized trial of thousands of women with early breast cancer looking at whether metformin, which changed the way your body uses glucose, helps. And again, metformin only seemed to work in that trial in HER2 positive cancers. Statin actually worked well in all types, but HER2 was the highest benefits, it seemed. Metformin only seemed to have any effect in HER2 positive ones. We don't know why that is. It didn't work for ER positive or triple negative. So yes, I think it is important, and it will become increasingly important, but it's a little bit complex because all cells again use sugars and cholesterol. So I think we're at the beginning of working out how to use that. One thing I will mention, there is certainly a lot of publicity about you shouldn't have any sugar if you've got breast cancer because cancer feeds on sugar. Well, that's sort of true, but so does your brain, and your breast cancer will your breast cancer will convert other things to sugar if there's no sugar about. So actually sugar makes little difference because your body will control it very tightly. What you don't want though is diabetes, and that in older people is usually due to obesity. So you don't want your weight to be high to affect the way your body handles sugar, because that also affects your insulin levels. And in fact, insulin is a hormone that can drive cancer. So that connection between diabetes and breast cancer being more likely is actually because insulin is higher in older diabetics, not the sugar. So eat healthy, don't become overweight, but if you have a bit of sugar, don't worry about it. Providing you eat your vegetables, good exercise, you can have a little bit of sugar.
Andy, there's just a couple of questions in the Q&A section as well. I don't know if
Okay.
you have access to that one.
Not sure, but tell me those and I'll answer those. And then there's one more question about denosumab, but I'll come back to that.
So one is from Susan, and she says I have metastatic breast cancer in the pleural space that was accompanied by malignant pleural effusion. It happened after 11 years on from early breast cancer. There are just a few lesions, and the malignant pleural effusion is now just a trace after 20 months on Ibrance and letrozole. The nodules keep shrinking. I've read that malignant pleural effusion has a very poor prognosis, but my oncologist does not agree with this in breast cancer. I'm very confused and wonder what your opinion may be.
Yeah. So a good question. I've come across this. I've come across people I'm seeing for the first time who've got a malignant pleural effusion and been told this poor prognosis. If you Google malignant pleural effusion, it will tell you 3 to 6 months. However, that is the majority. A lot of people with malignant pleural effusion, the average person has lung cancer, not breast cancer. And that's to distinguish a lung cancer that started in the lung and then has spread from within the lung. And those cancers are harder to control. The pleural effusions are a later thing, and so on. And so that may be valid for people with mesothelioma or lung cancer. You can basically forget about that figure for breast cancer. That is not true for breast cancer. And pleural effusions in breast cancer do not have any worse prognosis than liver or bone particularly. I have a patient actually who was told the very same thing, 3 to 6 months, and she's now been on the same treatment for over 4 years with no return. So now it's always a bit risky to talk about very good results because they don't apply to everybody, but that shows that it can go on for longer than that. I see Amy Hickman has a hand up as well. And is there another question you had, Melanie? And I'll go to Amy and Heather as well on denosumab.
So Dale just says, what is involved with targeted chemotherapy?
Well, when we talk about targeted chemotherapy, we're talking about these antibodies. An antibody is a protein that sticks to a very specific protein on a cell, a bit like those dodgy proteins I was showing you on the outside of cancer cells. So HER2 is a protein on the outside of cell, and antibody is something we make artificially. It originally came from immune cells. We manipulate that, and the antibody sticks to this thing that's all being well on the outside of cancer cells and not on your normal cells. And there's a chemotherapy molecule stuck by one of those linkers I was showing you the picture of to the antibody. And when the antibody with its chemo attached stick to the outside of the cancer cell reacts by taking that protein inside. It takes the chemo inside. So it's a bit like a Trojan horse. the cell recognizes the antibody stuck on, tries to get rid of it, takes it in, and then the chemo explodes basically and kills the cell. So that's our targeted chemo. And basically, if we know a protein that's on the outside of a cancer cell and not on most of your normal cells, we're in business with a new targeted treatment. So it's really these antibody drug conjugates, means an antibody and drug stuck together, chemo drug stuck together, are really going to be very much, may replace standard chemo within 20, 30 years. Don't tell anybody I told you that. This is between the 100 of us or whatever, but they may well come to replace standard chemotherapy in the next couple of decades. I'll cover the question on denosumab from Heather. So what are my thoughts about the use of denosumab? Now, denosumab is a drug that switches off your bone resorbing cells. So we've got cells that stick new bone on us, new mineral on our bone and make them harder. And then we've got cells that remove bone and make them sort of softer potentially. However, healthy bone needs both cells to keep a bone in good shape. And what denosumab does, because cancer tends to activate the bone destroying cells, if you will, or bone dissolving cells, and denosumab switches off those cells and stops cancer from dissolving your bone, and meanwhile your bone healing cells put bone back on. So the net result of denosumab, Xgeva it's also called, which is an under the skin injection, is to strengthen the bone when people have cancer. It's been shown to reduce your chance of getting high calcium, breaking a bone, or getting pain from a bone needing radiotherapy by about 60%. So over halves your risk of getting these things happen. There's about a 1% chance it can affect your teeth, though, especially if you need root canals or got infected teeth. There's a very small chance of it causing inflammation of the bone that goes away. And so we have to look after people's teeth before they start. We keep a close eye out for that. It is now being looked at in early breast cancer. Can it stop cancer coming back? And there's early signs that it may slightly help early breast cancer coming back, but that's it doesn't seem to affect survival in late breast cancer, but it does affect bad things happening with your bones. So we use it quite a bit. And then Amy, I don't know if Amy has a hand up. I don't know if that's a question. I don't know if you can type it in the chat, Amy. I don't know if I'm.
She just actually messaged and she said it's fine. You're answering it now because it was about bones.
Great. Okay, cool. Well, I get back into it. So I think I de-shared, so I'll reshare. So excuse me, I think I might have reshared the wrong screen. Having a technical hiatus here. There we go. All right, so that's the biggest part of the talk, but obviously some important, more practical issues around metastatic breast cancer that are important in living with it also. The one, can I pay for better treatment? I'm pleased to say, working in Australia, thankfully, that our system is generally aimed to pay for everything that works really well. It's not instant, so it can take a while, and if things work quite well, then it can be longer, and there's a lot more consideration by government and the people on government that look to decide what the best benefit is for public health money. But the people that I know that work in that system, they work very hard to try and make sure that public health money goes to the best treatments. But it is frustrating if there is an expensive treatment that may help that's not available, and we certainly appreciate that. There are some access schemes where a company that's developing a drug gets some good results and they feel it's likely to get funded. We can often get compassionate access, which is also great. Things that aren't covered by the PBS that have some benefit and you may read about. I want to cover things that people may be concerned they're not getting access to that may be helpful. In metastatic breast cancer, you can't get PARP inhibitors if you carry a BRCA1 or 2 mutation. These are drugs that affect DNA repair. If you've got one of these familial inherited problems with repairing your DNA, then PARP inhibitors in people who have these inherited genes that get breast cancer, PARP inhibitors can kill the cancer cells, but they don't work in normal breast cancer cells, so to speak. They are very good in early breast cancer. We now, in the last few weeks, have got access to PARP inhibitors for early breast cancer with people with BRCA1 and 2 mutations. We don't yet have it metastatic disease because it didn't significantly affect survival, though it did affect control, and we're working on further trials in that space. So there's a drug called Avastin or bevacizumab, which is used quite a lot in America. It stops the blood supply growing in tumor cells, and it can kill off tumor cells. And it was looking great. It helped the shrinkage rate for breast cancer, and it helped the control period. But then when it did become approved in America regularly by the FDA, it didn't quite get approval in Australia because we tend to wait a little bit longer for survival data, and survival was no better. And it turns out that once you've used this drug, the cancer's left more aggressive once the drug wears off, and the cancer goes quicker once you stop it. And so we're working on better ways to stop tumor blood supply that doesn't cause problems after. So Avastin is still not approved because it doesn't affect survival. There are a few new anti-estrogen drugs, not new tamoxifens, if you will, and these are tablets like tamoxifen but work better, and they're a bit like the drug fulvestrant that some people may be getting. That's an injection in the bum. It's literally a pain in the bum, and we've got novel tablets, and they're just coming along, and they may get approved but are not approved yet, and they look a bit better than fulvestrant and certainly less painful. PI3 kinase inhibitors, they're a drug we would quite like. There was this is a drug where it's one of those complex net I showed you in the cell of signaling pathways, and there's one of those that's alongside estrogen. We've found that if that gets jammed on, called a PI3 kinase mutation, then using a drug that blocks it can be quite useful. We do have trials ongoing in Australia. There was a trial with a drug called alpelisib, and that is approved in the US. It didn't have an amazing survival benefit, but it helped a little bit, and it's not been considered. It is quite toxic. It causes quite a lot of depression, quite a lot of high blood sugar, quite a lot of fatigue, and so if it were being clean and not causing too many side effects, then it probably would be approved. But it was more based on side effects versus its short benefit rather than that, and expensive also. Processes not covered by Medicare. These are not drugs, but processes. There's something called SIR-spheres, which people may read about, and this is a targeted spear for liver cancer from a variety of sources. There's not big trials in breast cancer. It's being used in bowel cancer and is invented in Perth, in fact, so which is great for us. And we have done a lot of the trials, and we're looking at a trial in breast cancer. I've been able to get compassionate access for a couple of people with breast cancer, and it worked okay. It's not a cure by any means, but most of the disease in the liver, it can control the disease for a period of time, but that's not available. Some lymphedema therapies, and this can be early or metastatic breast cancer, aren't covered. And lymphedema as a breast cancer specialist, I've done some work myself in trying to level the playing field of getting lymphedema help in WA with registries of lymphedema practitioners and filling in gaps, which is doing partly successful, not completely. So certain lymphedema therapies aren't available everywhere. I mentioned the Oncotype DX, which is the return risk test, which may predict if you need to add chemo to your hormones if you're an early hormone receptor positive breast cancer. That's not used in metastatic breast cancer. And I've already talked about CT, circulating tumor cell and circulating tumor DNA tests, which are not yet funded, but we keep doing trials, hoping we'll find how to best use them. And finally, and the one I'll talk about in a bit more detail, is you can actually have, you can have your DNA sequenced. You can get it done domestically. We're finding serial killers now through relatives that have had their entire DNA tested, and then we've got from long ago DNA from crimes, and we're identifying people who did them from those crimes, like the Golden Gate killer in San Francisco. We're also able to look at the DNA and compare the cancer to normal cells and see what's gone wrong in the cancer. And there are a couple of ones you can order online and get your tumor tested. Caris and Foundation One are just two ones. And the concept here is that that things that go wrong in the DNA in cancer may tell us what the best treatment is. It used to be not really feasible. The Human Genome Project, some people may remember this being in the news, and the first person had their genome sequenced, and it was it was an African man, I think, not for any particular reason other than they're the ancestral human from whom we all came not that long ago. And the first genome, it took 10 years and $3 billion to sequence the first human genome. Clearly, you can't have this done on your cancer. However, now it's done in 48 hours for $1,500. So that shows the amazing advance in technology here. So we now can do it on cancers if it's useful. So We have found some use, and you've already been told about some of them. I've talked about some of them. Breast cancer, we already know that HER2 targeting, and what happens in the HER2 gene is you get multiple copies of the HER2. So it is a mutation, even though the actual protein's about the same, but you get too much of it. So that's a gene change. And if you've got this gene change, then HER2 targeting has quadrupled or more the survival. In melanoma, we can detect one of those signaling molecules called BRAF, and we've doubled survival by targeting that. And lung cancer, that EGFR one I mentioned, the skin health one, that's doubled survival in people where that's gone wrong in their lung cancer. So there are examples where it's been amazing for cancer. And all of these relate to genes altered in cancer. So people went, great, now we can look at every gene and we'll just give drugs against the genes that have gone wrong and we're home and hosed. So why not sequence all genes in everybody and you target those damaged genes? It is a big wallet biopsy at the moment. These are the costs if you want to have it done yourself, but should the public purse pay, should your tax, you've paid your tax, should the money be put forward to that? So does it work? Well, unfortunately, it's not that great at this stage. So there was a study called the Signature Study. It took 2,000 patients and they had like hundreds of genes tested. Firstly, they looked at 300 genes, so exact figures here, which are known to be important in cancer. And about a quarter of patients, they found that there was a gene that had changed where there's a drug that could affect that gene. So they went, great, we're a quarter of people, we've found something existing today that might be helpful. They gave those drugs to the people, only 6 cancers shrank. So very disappointing. Benefit was seen in 1 in 300 patients. So you've got to spend, this is just cancer shrinking, you've got to spend about $3 million to get one cancer shrinking. And this isn't cure, this is just brief shrinkage. However, I think it will become important. This is why it's not funded, because we just don't have access to all those drugs and we don't have drugs for many things. But I think as we collect data, it will come into being over the next couple of decades. I think we will start to do this and it will become publicly funded. Talking about money, we're aware that breast cancer has its final hardships as well. So it's not just about paying for treatments, but there are many hardships. And this is a change of tack away from treatment now and it really relates to that question about access and super and insurance. So there are many things that make cause hardships, and what can we do about it in metastatic breast cancer? People's income is often down. They need time to go to treatments. It's disastrous for self-employed people where they may lose vast sums of income without any support or sick leave and so on. A BCNA report showed that out-of-pocket costs are somewhere between 3,500 and 7,000 for women, both without and with private health insurance. So those gaps exist and can be greater in the private system. And certainly, it's mentioned about accessing your insurance. Certainly, many people's super insurance, in particular, our social workers have found $200,000 or $300,000 worth of insurance people didn't even know they had access to through their super. So do check with your oncologist and with the social work system through the various hospital departments or your GP, see if there's hidden money that you may be eligible for. Certainly, applying for super early is often an option. I've already answered that question. I'm very happy to give a more pessimistic than I believe view to help people access their super. It's your money, you should have it, particularly in this scenario when you want it. Oncology social workers I've mentioned can help. And the Cancer Council, Western Australia and Breast Cancer Care have got some financial support for living expenses in extremes of hardship that can be applied for also. And there are some information systems. Again, these 2 organisations and Breast Cancer Network, there are some online tips for that. Things that are always free, just as a brief final point on that, clinical trials, you should not be paying for a clinical trial. There are some alternative health practitioners who are putting people on trials, but you're having to pay for stuff, and that's not ethical. It's not really a proper trial. So if you're paying for stuff that they say they're doing a trial, they're trying to collect money while doing a trial. Trials should always be free, and everything about trials should be free. There should be no out-of-pocket costs. One thing that's never free, as everybody knows, is hospital parking. And that's true for doctors as well as patients. And I go to hospitals other than Fiona Stanley, and I am equally getting a major wallet biopsy. We are trying to do things about that, but that's one of the things we're finding hardest to address. Curative treatments, well, we're getting, along with that, free hospital parking. We've not made much mileage. So my apologies for hospital parking. Chapter 5, moving to clinical trials, be on a clinical trial. Clinical trials are they're great and they've got many advantages, though they're not for everybody. And some people prefer to know that they're getting a treatment and it's, and what its results are. There are some pros and cons, therefore, of trials in the balance. The pros of trials is you may get a new drug that's effective years before it's available. As mentioned, somebody's on Ibrance, and I was involved in the early trials of Ibrance, and we were giving Ibrance 6 years before it became publicly funded. So, and that I've got people who are on the Ibrance trial and are still on the drug from being on a trial, and it's now available in the public system. But then you may be given a drug that's not successful, though, obviously. You get closer monitoring now. That getting more tests isn't what everybody wants, or more visits potentially. And we do want people to get on with their lives and do what they want to do also. So that can be good, but it can be a two-edged sword. It contributes to knowledge and options for future patients as well. So that a lot of people there, well, if I get help, great. And if it's a negative trial, it's one thing we don't have to take forward, and we can concentrate on other things that may work. So certainly a lot of people, helping their peers as well is not without its benefits. And you also may, if you go on a trial and don't get the drug on the trial participants where you went on a trial and got a control drug and didn't get the new drug, if the new drug's shown to work, you're often given access to that drug and offered it on the trial, when somebody who wasn't on the trial would not get that drug. The cons, well, you might get an ineffective drug before and know its ineffectiveness. Generally, with trials in breast cancer, we're adding a drug. We've got a space where drugs are not particularly effective. So it's unlikely you'll be getting an ineffective drug and you could have had something more effective. That's a rarity, but you might get something that doesn't work and you had some side effects that didn't benefit you. You may get more visits to tests. That's the opposite for the closer monitoring, the other side of the coin. If you're regional and remote, that can be traveling long ways. And we're now trying to develop teletrials, so people in regional and remote areas are not disadvantaged by that. There may be unexpected side effects that come out of the blue that nobody knew about, that we can't forewarn about. And occasionally it may be in the place of more effective usual treatment, though that's a rarity with breast cancer, I think. The important things to know about trials if you're going on one, always voluntary, so don't feel pressured into it. If the doctor's saying you really should go on this, well, if you don't want to, don't go on it. And do feel free to get a second opinion from your GP or another doctor if you feel there may be a little bit of untoward pressure or it's not certain. It should be always voluntary. We should give you an even view. We should not be biased towards putting you on a trial regardless. You can come off it at any time. So if you start it, you don't like it, you can come off. That's your right at any stage in the process. Your doctor cannot stop you coming off. Absolutely 100%. Generally, a cancer must be growing before joining most trials. So I get queries about trials I'm running. I'm on this treatment, it's working well, but can I go on this trial because maybe this treatment's better? The answer to that is no, because you're already under control. A trial is measuring shrinkage rates or control rates. If you're already controlled and you go on a trial, we don't know if it was from what you had before or not. So we do have to have the cancer growing before you go on a trial. We do have randomized trials where you get the standard treatment or the standard treatment plus something better or just something that may be better. And so we don't select that. So some people don't want to go on a treatment where they know what they're getting, don't want to be randomized. And one of the big things that the different centers and hospitals have different trials. And also trials can open and close at short notice. So sometimes trials are open for a small number of years, but particularly the very early trials can open and close over a few weeks. So sometimes a trial may be available, and by the time somebody gets to needing it, it's not there. Where to go for information is one of the tough things about trials is that different centers and hospitals have different trials. So if you read about a great trial that's looking really promising in the paper, chance of your center and your oncologist having it is modest, depending on what that newspaper is. If you're online for the international literature, then it may well not be present. Though linear research, which is I help run Linear, which is first in human trials. We have more early phase trials than any other center in the Southern Hemisphere. So WA is punching ahead its weight in trial availability, but still many trials are not available in some places. So this is Linear, this is early phase trials, and that takes us through to later phase trials when we've shown a drug is safe, we've worked out what the dose was, and that'll be expanded and compared to new treatments. And we're doing this in public. Fiona Stanley's where I work, so we've got lots of trials. Hollywood's got lots of trials, for example, and many other centers are great for having a range of trials. We also speak to each other as oncologists. So I've had I have one trial called the Destiny 12 trial, one of those targeted chemos. Sorry, Destiny. It's called the Sapphire trial. Used a targeted HER2 treatment, and I had 6 patients on the trial from 6 different hospitals, one from Fiona Stanley, 2 from private, somebody from Rockingham, and so on. So we talk to each other, and we can put people on trials at other hospitals. We try and keep in touch with what each person's got. Much harder if we're talking over East or in America. People do go over East, and I do refer my patients if there's a promising trial, but expenses are not covered for them flying there and accommodation. The trial itself will be covered, and flying to the States or the UK or something for a trial, it may be expensive. So trial costs for the trial are covered, but not for the getting over to have them. The Cancer Council has a great booklet, Understanding Clinical Trials and Research. It's good to read if you're thinking about trials or you've been offered a trial. And there is some specific information. This is just to tell you how many trials are going on. So sometimes people bring me a bit of newspaper and say, oh, I read there's a great trial for breast cancer. Can I have it? I go, well, do you know what it was? And they go, no, I thought you might know. Well, there is nearly 13,000 breast cancer trials going on in the world, and this is probably an underestimate. And somewhere between 300 and 400 in Australia. So if the newspaper just said breast cancer, I will need a little bit more information. So if you've seen something that interests you, clip out the coupon. It may still not be apparent. Take all the information you can in on it. Western Australia, there are websites where you can look at clinical trials that are ongoing. There is one for Australia, the Australia-New Zealand Clinical Trials and Research, and then clinicaltrials.gov is an international one. So, but once you get international, then it may be harder. So moving from drugs and paying for stuff and conventional medicine, how can you help yourself? What may help on top of all the stuff that we do? Drugs. We give lifestyle advice as well, and what may help. Well, eating's mentioned, and certainly cancer is a metabolic disease. We found that obesity may, in particular, may produce chemicals and raise insulin that may drive cancer, and certainly. So that's probably the biggest thing in terms of cancer and metabolic disease. Guidelines for eating. There's surprisingly little research in metastatic breast cancer. We do have quite a lot in early breast cancer. A lot of what we say is extrapolated from early breast cancer. Do ask to see a dietitian about the hospital for specialized advice if you wish to get some advice on that, and they'll be able to guide you as best as possible. Aim for real foods and a balanced diet over supplements. And remember not to starve yourself too much, as protein, you can lose protein even if your weight's high if you starve yourself, and so you don't necessarily change the right bits of weight. So do keep up protein intake even if you're on calorie restriction. And actually muscle almost seems to be an anti-cancer tissue. It's very rare that cancer goes to muscle. I do some work with exercise, and muscle related hormones may help against cancer. Check and correct vitamin D. There are associations in early breast cancer with low vitamin D and it being more aggressive. We haven't got research in metastatic breast cancer, but if it's low, then certainly I would suggest people supplement it. Don't keep checking it. If it's good on your diet, then you don't need to check it. You don't need to supplement. If it's low, then if you go onto a supplement, you probably don't need to keep checking it. And if it's normal, I wouldn't recommend taking vitamin D because your body will just get rid of it and it may have downsides. So just have it in the normal range. And it's hard to do research on vitamin D because so many people already take it. Most of the people you ask again, oh, well, I'm supplementing. So we can't find people who aren't supplementing to put on a trial. Guidelines for other stuff. This is a misty picture because it is misty. We don't really have evidence in metastatic breast cancer for exercise, for vegetable consumption, for alcohol, vitamin D. There appears no clear detriment necessarily for obesity as far as we've been able to prove in metastatic breast cancer, but that controls for people not being diabetic and having good vegetable consumption and exercise. So generally it's best not to be significantly overweight for general health. What we do recommend, though, in early breast cancer, exercise is proven to reduce your risk of it returning. Vegetable consumption also does so. Alcohol may have a slight increase in risk of certainly initial breast cancer, and vitamin D seems to make it behave less aggressively. There's no downside to getting good regular exercise, getting good vegetable consumption, minimizing alcohol, even if taking some is fine, and keeping a reasonable vitamin D and not being significantly overweight. As absence of evidence doesn't mean that these things don't help. And I've talked about this really, but these are the benefits of breast cancer returning in absolute terms from fruit and veg, exercise, alcohol and obesity. So fruit and veg and exercise protective, alcohol and obesity increase your risk of return. This is just talking about a glib view about the fact that modern lifestyle and obesity is increasing, fruit and vegetable consumption is down, people lead more sedentary lives as every family's got 2 cars and so on. This is the modern couple, obviously showing there may be a little bit of a pot here, consumption of alcohol being conspicuous, and there is no sign of exercise or vegetables. And then really coming to the end of my talk now, what about alternative treatments? And we fully appreciate, we're telling you about we've got this drug or that drug, or we don't have anything, or this one's okay but not amazing, could go on a trial. People want to make sure they're taking everything that may be helpful. So when you see one of the things to bear in mind, a lot of the alternatives are sort of, there may be a published paper showing it kills cancer cells in a dish. Almost many of our treatments entering trials kill cancer cells in a dish. Well, it's one of the reasons to do a trial, but only about 2% of drugs that enter a trial end up being a useful treatment. So it's a lot of the things that we're very excited about may not prove to be useful treatment. So it is something that makes us do trials, but it's not something that makes us treat people. There are intertwining concepts here, drug-based and non-drug-based. Well, a drug is defined as something that has an effect on the body, can be good, can be bad. So if something is non-drug-based, the official definition means it has no effect on the body. Normal cells, cancer cells. So officially a non-drug would not affect cancer. Anything that can affect cancer cells is a drug by its very definition. Obviously, people tend to think of it, therefore, as it's a natural substance versus artificial. But many of our drugs are actually natural in originality. So we don't draw that distinction either. Anything that makes a difference, bad or good, is a drug. Natural and artificial, we're happy to use either. Alternative and complementary is maybe a more important divide. Alternative, really sort of defined as it's an alternative treatment, implies that it's an alternative that gets you to the same place as a normal treatment and as a conventional treatment. An alternative route into town gets you into town, whereas an alternative treatment doesn't generally get you to the same benefit as a conventional treatment, not as far as we know. And as I say, with only 1 in 50 of things that we get excited about do a trial actually working usefully at the end of the day, many alternative treatments probably won't work, but there may be hidden in there some that may work in due course. We don't know. So certainly that's the difference in alternative and conventional. We only draw one distinction, proven or unproven. We give proven treatments where we consider that they're safe enough and the benefits are enough to have that balance. If it's unproven, but we think it looks exciting, we'll do a trial, but we don't give unproven treatment outside a trial. Frequency of use, so we know that lots of people use alternative and complementary treatments, and I've no problem with people using them. I do like to know what people are using because it may mess with or overlap with conventional treatments, and it may actually be known to be harmful, but the person hasn't discovered that. So I do like to know, and I treat to, keep in contact with my patients about this. This shows how many people before and after cancer diagnosis in Canada were using various things. And as you can see, the light grey things are lots of people using alternatives already, about a third of people already, and probably about 40% it went up to with cancer. And biologic products and supplements went up, and alternative medical systems, which is, I think, things like Reiki, things like homeopathy, iridology, and so on, went down. This very complicated slide just shows chemotherapy drugs for breast cancer and where they work. The yellow bits are drugs, though, and this just shows how many of our drugs, the green ones, are natural products. So as you can see, half our chemotherapies that you may be getting are natural, herbal, you could call them. They would be defined as herbal, but they have significant side effects. And this shows the plants that come from yew trees, periwinkle flowers, marine sponges, and Adriamycin, the red peril as it's known, or the red devil for breast cancer patients get it, and I'm sure I'm talking to many people who've had it, comes from the cultures that grow on the shores of the Adriatic. Alternative and complementary. Alternatives are given in place of conventional treatment. The goal is generally an anti-cancer effect. Generally, there's not scientifically tested comparing patients to receive standard no therapy. If it was proven, we'd use it if it was safe. We have no issues and jurisdiction of not, it doesn't have to come from a drug company. We can use whatever we want. And if it's proven, we'd use it. If it looks exciting, I'm happy to trial it. It is difficult, though, for the alternative health industry to do trials because they're expensive. And it may be that if you really want to show it works or doesn't, you have to compare it to something that's conventional that has activity. So we do appreciate that the alternative health industry does not have the pharmaceutical industry's budget. It doesn't mean that the drugs definitely work and it's been suppressed by the pharmaceutical company, because if there's a trial, we can still look at it. But it is difficult to compare these things. Complementary, given alongside conventional treatment. Goal is to maintain wellness or improve tolerance of standard therapy. Laudable goals, and we're absolutely happy with that. There are some trials looking at adding conventional and like anti-nausea, anti-pain, or even adding a complementary treatment on top of conventional to see how they work. And there are some complementary things that we do use sometimes. It's easier to trial as usually everybody gets the standard treatment, we're adding something complementary. And is an alternative an alternative? There is a little bit of research just looking globally at people who went, I'm going with an alternative route rather than conventional. This is a statement. If you Google alternative breast cancer treatments, this is the first link. Alternative integrative breast cancer treatments avoid surgery and long painful recovery time after conventional treatments. This is early breast cancer, talking about, obviously, to a certain extent. Side effects are lower than conventional surgery, chemo, and radiation. Not aware of any alternative treatments been shown to supplement for good local treatment, and alternative treatments are more effective than conventional in most cases. There may be ones hidden around that are effective, but we certainly don't know. When we look at a study at the MD Anderson, they're very much holistic in looking at alternative treatments. They looked at people who had opted for alternative treatment only compared to standard with or without alternative treatment. And they saw that people with breast cancer who opted for alternative treatment, 42% of people were deceased in the study time compared to 13. I'm very happy if people want to try alternatives. I'll partner with them on that, check that it's safe, and I'm happy with it. But I don't want people just to go with alternative treatments, particularly in the early curable setting. Final slide, medical marijuana. You just can't avoid talking about it because it's so popular. I think it's popular because it's natural and because it's considered like almost naughty because it's banned, sort of. I don't know. I've used it in London for nausea. It's okay for some non-cancer pains. It's not been shown to really add much, and there are too many side effects to add to cancer painkillers. It may be okay for nausea, and I did have it in London. It was addable to nausea, and it did work well for some patients. So if I had it, I'd use it a bit. There is some evidence in the cell dish that it may be beneficial against some cancer cells, but otherwise there are some other cancer cell type it wasn't good for, and they might actually have grown a bit. And the only trial of showing it's an anti-cancer treatment was in 21 patients with brain tumors, not breast cancer at all, showing that 8 out of 10 versus 5 out of 10 were alive at 1 year. But that was only 21 patients. And there are a lot of other negative studies. So I think caution is needed, as some cancers have marijuana receptors, if you will, that may cause the cancer to grow. And this is Fran's plan, where Fran Boyle has looked a lot, and she's a medical oncologist who has a very big focus on holistic care. Her advice is, if it sounds too simple, it probably is too simple. If you go, that's just too amazing, and that works for everything, it probably doesn't, because different diseases have different causations. If it tastes foul, well, it's probably not good news anyway. Don't try golden tea. I had a patient who was taking golden tea for stomach cancer, and I'm a bit of a researcher, so I did have a sip of it, and I couldn't get rid of the taste for about 4 hours. So it was almost, even if it works, it's not worth it. If it costs an arm and a leg and it's putting you under financial stress, certainly feel free to discuss with your oncologist, because you want some decent information before you put yourself under financial stress. Automatic doesn't necessarily mean safe. Ask any practitioner, oncologist, alternative practitioner, about results for your situation. I've seen people have been told, oh, it's got a 90% success rate. It's mainly used for fatigue or against common cold. Literally, I've seen that. And actually, they haven't really treated many people with cancer, never mind breast cancer. So if you hear about results, we want to know how many people they've treated with your type of disease. Use a registered practitioner as a registry. And do check, if you want to try something, if it might interfere with your current treatment. And this is, I promise you, the very final chapter, communicating with oncologists like myself and others. This is about oncologists. We try and coordinate with each other to read off the same page, and that's why being told that you may have a survival of 3 to 6 months, and by one doctor and by your oncologist itself 5 or 6 years, is very distressing, because you can't believe any. You go, well, I've got no information now. So we try and work to have multidisciplinary coordination and treatment, and we've all agreed on the plan and the prognosis as best we can. Tips for talking to your oncologist: ask anything you want. Don't feel that if you don't know the answer, it's stupid not to ask, to be honest. So there's no such thing as a daft question. Even if you think it's maybe mentioned, feel free to ask again. We know when people are told that they've got a cancer or it's a metastatic cancer, you don't hear much after that news, and so you may need to come back to it in particular. Prepare questions ahead of time, because you may forget at the time, and so it's good to make sure you've asked what you want rather than get out into the waiting room again and go, oh, damn it. If you want to know about a new therapy that may be in the newspaper or maybe online, take the specific information you had. There are so many of them, so many trials, that your oncologist may or may not have come across it. Don't keep quiet about pain. The emergency specialists say we have more painkillers than you have pain. Now, that's a little bit glib. Painkillers can have their side effects, but usually we can get pain fixed or largely fixed. We have many different processes. Don't keep quiet about it. Keep your oncologist up to date with alternative and complementaries, just to make sure there's no antagonism between the two treatments. People always want to see their consultant, I find, working in public system where I'm the consultant, but bear in mind, registrars and advanced trainees have a different view set, and they've done general medicine much more recent than me. So if you've got general medical problems, they may be the person. And so don't think just because somebody says a trainee doctors are actually the next senior down from consultants if they run oncology. So I don't call them trainees, I call them senior registrars, because they've been in medicine for 8 years and oncology 2 or 3 years. So they still have a lot of experience. So don't be put off by I'm a trainee. And if you can't communicate with your doctor, then consider a second opinion, because it's very important that you can get good information. There's a chemistry between you and your doctor, and you feel you can ask anything. You feel there's no such thing as a stupid question. If you're finding you're being made to feel it's a stupid question, you maybe need to change over. Some people embarrassed. I have some people that I see just to chat. They're looked after by an oncologist. They came to see me as a second opinion. I'm happy with the treatment, but they want to stay and come and have a chat, because they feel I give them a bit more information than their own oncologist. But they were happy with the care otherwise. And the Cancer Council again has questions to ask your doctor. And that's just getting a second opinion. It's always your right to do so, so don't be embarrassed about it. Your care will be unaffected. Nobody's going to be upset. I arrange, if people want a second opinion, that second opinion, if people want it from me to put them in touch, or their GP can put them in touch, and so on. So care is unaffected. Nobody is upset. We all talk to each other anyway. Many people from many hospitals, I've been involved in their training, and they talk to me about their cases. First opinions are a priority, so we won't jump in and prioritize a second opinion if you've already had an opinion from an oncologist, except in very special circumstances. So you may have to be a bit patient. You need to take good documentation. Just going to your GP and asking for a second opinion to be raised and arriving with none of the complex treatment information you may have had, especially if you've been under care for a good while, is difficult for the second opinion. They may not be able to give you the best opinion, so take good details. Do look for a breast cancer specialist, because it is complex, and we all tend to manage just a few cancers, not all of them. Do ask your oncologist for help, especially if the problem's unusual or rare, rather than being shy of doing that. And as I say, if it's communication or care issues, you can get a second opinion just for that, even though you may be happy with what's helped. And do choose an affordable alternative close to home. It's rare that you may get a Harley Street specialist, but I can't say. Firstly, the guys in private that triage bigger gaps do not tend to be. I can't think of a single instance where that person's better than the general run of the public specialists. You're not particularly paid better in private. A lot of private oncologists, there's some very good ones, don't get me wrong, but it's not a better system. The advantages are you see the specialist the whole time. There may be certain things you get, but there's some bills you get as well. So generally, we design the public system to be equitable. And very finally, when is it okay to stop treatment? And there can be a practice, and this is certainly the case in the States. We're a little bit more philosophical here, but it may be that we're just assuming people want the next treatment. Don't be afraid to say, how about a rest just now? And this, I think, is about my final slide. You may stop because you're just miserable on the treatment, and you want to know what the next alternative will be. It might be really inconvenient and it's IV and it's weekly, and you want to say, look, I'd like to transfer to something that's more convenient. You might want to try something new for personal reasons, that you want to give something a go. Might want to try something alternative. You may want to go on have a break just to have a rest and get back to normal life. You may want to go on a holiday, and the cancer maybe have disappeared, and you're thinking, well, I'm on treatment, it's been a long time, can I have a break? And we certainly discuss that. People are 10 years on Herceptin, for example, can they have a break? Probably they can, and we discuss what the evidence is. And it's always your right to stop treatment. And the device you get, though, will depend on how the cancer is behaving. If the cancer's racing away and we're just starting a new treatment, or if it seems to have taken off at the end of that treatment, we're starting something new, we may say, well, let's wait a bit and get things back under control before we consider a break. It may depend where it is. If it goes and moves on a bit and it might cause a significant problem, we may be worried. The current treatment may be successful. We're a lot concerned about losing control. It may depend on what the cancer's done and whether it's suddenly taken off before. And if we do stop, we're likely to do another scan or some blood tests quite soon just to keep an eye on things. And I think last two slides, keep saying the last. Traveling on treatment, we do try and get people to where they want to go, and I've had many patients with metastatic breast cancer have done some quite exotic holidays, which is great. Choose countries with reciprocal medical agreements if you can't get insurance, and insurance can be an issue. Get a letter about your medications. You don't want to be stopped at customs for a long period of time. Take a copy of your blood results and your latest scan and a letter about what's going on, just in case, so you can give it to a local doctor. Don't do crazy things. It's your right to do so, but there are certain things. Bungee jumping with bone metastases, I did have somebody who got injured doing that. So bungee jumping is questionable at the best of times. Jumping off a completely adequate bridge into space is questionable activity, but I have had somebody who was happy enough to have done it, but I did have an injury. Think about a bit more risk of clots with certain treatments or cancers, so think about clot prevention. Take antibiotics with you if you're in a space where infection may be at risk. And don't book too far ahead. So don't go on arrange your lifetime trip in 9 or 12 months unless your doctor said that's fine. Probably think about it, hit a gap that's close to that, and have a good time. And this is definitely the last slide. And this is about, will we cure breast cancer? And this is just the longest ranging stuff. This is Herceptin, and this is that Cleopatra study. And at 8 years, 37% of people were still alive from their breast cancer, and many of them had full control of the disease. And we don't know yet about 10 years because we only got pertuzumab 8 years ago. And there has been a study stopping Herceptin at 10 years. 12 patients in this study stopped Herceptin. They had full control of the disease at 10 years. 7 had no signs of active disease. 12 had full control. 7 had no sign of active disease, and of those, 4 patients stopped. So we had only 4 patients stopped Herceptin with no sign of the cancer being there at 4 years, and all 4 have no sign of cancer return, an average of, I think, 2.5 years later. So people who have stopped with the cancer fully controlled, they got 2.5 years on and there was nothing. So we are starting to look at research in that space. And that's the end. So sorry, I've run over time. I'm not known as a professor of time management, but hopefully it's been useful. I'll stop sharing and answer any other questions, though. Melanie, we're okay with it's not going to suddenly switch off or anything like that?
No, as long as you're happy, that would be absolutely amazing.
I'm all good. I'm all good.
There's a couple that you'll be able to see in the chat. And then if you're happy, there's just a couple that have come in through another avenue.
Okay, well, I'll take the ones that I can see in the chat. So, Sandra wants to know about abemaciclib, and with the CDK inhibitors, do you continue them as long as they work to block the cancer? And can the body handle it, or is there a certain time frame? Great question. The answer for most treatments, and abemaciclib and the other CDKs, as palbociclib and ribociclib also, the answer is we do continue them for as long as they're working and people are happy to continue them and the side effects are lower level or not there. So there isn't the CDK inhibitors, which they work for a long time in many people. So it's an important question. We've not found hidden side effects. They don't damage organs. We've not if people are on them for a long time, there can be side effects. Abemaciclib can cause diarrhea. There is a rare effect where it can cause inflammation of the lungs, but that doesn't tend to be many years later. It tends to be within the first 6 months to a year. So abemaciclib, we've not identified any problems with any late organ damage if people are on it for into a number of years. And that's not true for absolutely all of the drugs. A lot of the blockers, they're fine. Some of the chemotherapies, like the red devil, that can damage the heart if you're on it for a long time. And it's not like Herceptin where it's temporary. It is ones where more dose can cause more damage. We know there's a very safe initial treatment period, and we try not to go outside that. The U-tree drugs, the taxanes like paclitaxel and docetaxel, can damage nerves, and we keep an eye out for it. We just stop the drug or reduce it if it starts to cause tingling or numbness, as that can be a permanent thing. So they're two classic examples where there can be a long-term damage, and we keep a close eye out. But all of these ones I've been talking about, abemaciclib, the HER2 blocking, there's not a cumulative risk of heart damage with the HER2 blockers. Some people are on them for decades without a problem. Sally Ann's asked about research on side effects of the new targeted therapies. Well, the side effect research always goes hand in hand with the benefits. So the ethics committees include people who are consumers and doctors and community advocates and so on, will look at trial design, and a trial will not be approved unless it looks at side effects. We also much more frequently now look at what we call PROMs, patient-reported outcome measures, and that's about quality of life, not just did you get like a heart problem, or did you get diarrhea, or did you get nausea, but what's your quality of life? Did it affect you psychologically? Did it affect your wellness generally, and so on? So these are being built into all of these trials. One thing to say about it is we know about the side effects before we know about the benefits sometimes, because we don't know how long the benefits will go for, but usually the side effects happen or don't fairly early on. So there is absolutely as much about side effects as about the new targeted therapies as there is about benefits, because when we update a trial and that study at 8 years of the pertuzumab, trastuzumab, we got 8 years of side effects also, and there are no new ones. And Monica is welcome for the presentation. Thank you, Monica, for the feedback. Melanie, we got other questions. Sorry, I can't see. I haven't got the...
Sorry. Yes. So just one from Dale. Do you know anything about turkey tail mushroom as a cancer treatment?
I have had a quick look into it. I did not find anything in breast cancer. Somebody did ask that one. And I couldn't find anything that suggested it was harmful. I couldn't find anything that suggested, certainly in the breast cancer space, it's going to interfere with hormone blockers, or HER2 targeting or things like that. So as best I could tell, I didn't have any safety concerns. I couldn't see it mess with any treatments or reverse anything, but I couldn't find any information on benefit in breast cancer specifically. Yeah.
Oh, yes. So there's another one on the subject of alternative. Have you come across fenbendazole for the use of breast cancer treatment?
Yeah, so fenbendazole is a repurposed drug. We have had a look at it, particularly in triple-negative breast cancer. There have been there's a few drugs that it's strange, because there's actual dosing and dosing recommendations for treating cancers, and fenbendazole is one of those. But there's not a trial where doses have been compared to say, yes, this is the best dose or not. That one, there's quite a lot of case reports online, and it's, when we look at evidence, there are case reports, there's occasional breast cancer ones and other cancers, and we don't know how many people. So there are case reports where people have had fenbendazole and they got success in their cancer treatment. What we don't know is whether they were on other stuff, and people usually are on other stuff. We don't know how many people got treatment and it didn't work, because the case reports online are always the successes. In a trial, you cannot say this worked for 78 people. You've got to say it worked for 78 people, it didn't work for 1,000, or it didn't work for 7. So So there is some evidence that in cancers broadly, there were some anecdotes suggesting some success. Couldn't tell whether it was the drug used alone, certainly not randomized and adding it or not to an otherwise level playing field. It can have some side effects, but I don't have major concerns of it. So I think it's overplayed in the online literature because these are anecdotes and these are people who sell the drug for to give a benefit, but still people, alternative practitioners, they're there they want to help people, right? So it's my experience in general. They may have a somewhat less evidence-based strong belief in a particular area, and that drives it, and they don't necessarily consider all the balance of evidence. But then there are some excellent ones that are going, look, this may help or not, and they're trying to collect information as well. So fenbendazole, there are some anecdotes online. It doesn't tell what other treatments people are on or how many negatives there were, so beware of it from that personal point of view. But I don't have it's not something I take instead of a very good looking conventional drug, but it's something I consider if I needed something, and it can impact on other cancer treatments. So ask your oncologist and they'll ask their pharmacist and they'll have a look at it for you.
What about the 2 to 3
Long answer, sorry.
injections?
And there's just, I think, 3 more questions with the denosumab that we spoke about earlier. There was a question about when it can be changed over to kind of 3 monthly.
Okay, yeah. Good question. So just for the background of everybody online, this denosumab is the drug that's used to stop your, very simplistically, cancer devolving the bone, if you will. And there is 2 different treatments. There was an earlier one called Zomida, which works in a slightly different way. It coats the bone, but stops those cells devolving the bone. And then there's denosumab that sort of switches off those cells. And we've done trials of both of them, giving them monthly. Both of them showed almost sort of around about a halving of problems in the bone. Denosumab was very slightly different. It was like 60% versus 50%. There is some research on Zomida, because it's been around for a lot longer, showing if you have good cancer control, then you can go to 3 monthly and it's just as good. Denosumab, we presume that applies, but there isn't the same evidence because it's just not been done. We've not had it as long. What do I do if my patient has been a year and there's been good control with no sign of the cancer growth? Then I consider going to 3 monthly at a year as a minimum. If there's been slow improvement and the result bones are still quite fragile, I might consider going to 2 years, but generally about a year if everything's going really well. Yeah.
And just a question about oligometastatic disease. This lady just wants to know your thoughts on it generally, and just her oncologist has told her it's got a more favorable outcome, and she wondered if that is true.
Yes. So just for the whole community, oligometastatic disease refers to a bit of metastatic disease, if you will. So it usually refers to people who's got 1 spot or maybe a couple of bone spots or 3 bone spots. Usually we've tried, because with oligometastatic disease, we might be able to give it radiotherapy as well as a whole body drug treatment, or even give it just radiotherapy. It's 1 spot and keep an eye on things, and that's a choice. We tend to give local and a drug, and so it's an evolving thing. As we've got better targeted radiotherapy, we've had to define oligometastatic disease. It usually means 1 organ, and in an area, it's confined to an area where you could give it some local treatment as well. So that's what it is. It is true that if it's oligometastatic, that the prognosis is somewhat better. There's not big trials because it's relatively uncommon. Most people have a moderate number of spots, such that it's not that. It's probably only about maybe 10% of people. It does have a favorable prognosis. We do give local treatment, which may help the control, and we do find that it's hard to give a number, but it is more favorable. You've not been fibbed to. Yeah. The other thing that we do see sometimes is oligoprogression, which means that there's cancer in a number of spots, but when it starts to grow, it's only grown in a small area. And that means it's just growing a bit rather than there's a bit of cancer. And sometimes we may give radiotherapy, it's just growing a bit, or some other local treatment, and then carry on with the drug treatment because it's working with everywhere else. And that's an increasing thing. We're often not throwing the baby out with the bathwater, and we'll give local treatment, carry on with the same drug, and then keep an eye on things. And we can maybe get more benefit from each drug as we go.
Thank you so much. And just the last question. So this
Yeah,
is from a lady with triple negative breast cancer. She had first line treatment with chemotherapy and immunotherapy, but sadly has now progressed. So they are doing second line with Trodelvy. She had a fine needle aspirate done, which had an insufficient sample. And she's just saying that she's concerned about how useful this new treatment will be for her because she doesn't know her TROP2 status. And she said what can be done for patients like her where aspirates don't get the information they may need.
Okay, so just to fill in the general audience, so we talked about these antibodies with chemotherapy stuck on. The one I talked about most was the HER2 one, which is the first ones we had developed. I also mentioned briefly at the end of the triple negative talk, I don't have a slide for that yet, that we do have a second antibody chemotherapy fusion called Trodelvy. It sticks to a separate protein that can be on the outside of triple negative and ER and HER2 positive cells, and the antibody sticks to TROP2, and there's a chemo stuck to it. What we do a biopsy sometimes when people get their cancer starts to grow again. The main reason we do it to see if it's still triple negative, to check that the HER2 has not appeared or ER, because we may have new treatments we can add to our toolbox. So that's the main reason we do the test. Most cancers stay the same, but not all of them. We don't actually need to measure TROP2 because we've found that Trodelvy works even when you've got almost no detectable TROP2. So the main reason for the biopsy is not to test TROP2, it's to just check that it's not changed from triple negative. Trodelvy will still got a good chance of working, but there's maybe other things we can think about that may also work. And so the lack of biopsy information for Trodelvy is fine because it works very well in triple negative cancer, not on every person, but it's been very useful. We don't have to worry about that biopsy from that regard. We do if we may we may have a drug that does need some information from the new tumor. So in that case, we may, if there's a really good reason to do it, suggest another biopsy, and it's the person's right to decline or go with that. We'll try and make sure a biopsy is safe. But for this particular instance, no problem with that lack of biopsy information, because it certainly doesn't mean that Trodelvy is not a good choice.
Brilliant. Thank you so much. And I think that's all the questions now. That was a fantastic presentation, Andy, and just the feedback coming through just shows how valuable it was. And thank you so much for staying on later than you said you would to answer all those questions, because I know sometimes people find it hard to get some of these questions answered. But thank you so much for being with us here today. We really appreciate it.
That's quite all right. It's my tendency to chat longer than I should.
No,
so that's really, quite all right.
Yeah, very valuable.
You're very welcome, everybody. Thank you for the feedback. Any suggestions as well, if people, I likely give a similar presentation in the future, and so if there were things that people wanted to know about, then I'm happy to put it into future versions. Yeah. Okay. Thanks very much.
Thank you.
Enjoy your rest of your days, people.
Thank you for joining us today, and it's been wonderful having you all here. As Andy said, there are no stupid questions, so if anything has come out of this webinar and you didn't get a chance to ask it, or questions come up later on, do take them to your oncologist. Equally, do reach out to your breast care nurses who can come with you and help advocate for you as well. And anyone that's in WA, you can always reach out to Breast Cancer Care WA here, and we can point you in the right direction. But thank you very much for attending, and have a lovely day.
Cheers, everybody. Thanks for listening.